I would like to thank the organizing committee for the nice conference, and I appreciate the invitation and the time. I saw on the agenda that there will be two other presentations discussing specifically pulmonary hypertension in left heart disease, which is one of the categories of pulmonary hypertension, of course. So I figured that my presentation would best serve the session if it's more of an overview about pulmonary hypertension with emphasis on the guidelines. My presentation will discuss a little bit on the definition and classification, pathophysiology, clinical presentation, diagnosis and management in accordance with the guidelines that we have in our cardiology community from the 2009 ACC guidelines. But as a pulmonary hypertension community, we have most recently the World Symposium on Pulmonary Hypertension, which was held in 2013. The World Symposium on Pulmonary Hypertension takes place every 5 years, and it basically gathers all experts or a group of prominent experts in pulmonary hypertension to discuss updates in diagnosis and management of this condition in accordance with the new literature. So just quickly to emphasize, and this is according to the 5th World Symposium on Pulmonary Hypertension, the hemodynamic definition of pulmonary hypertension is having a mean pulmonary artery pressure of more than 25 millimeters of mercury, while pulmonary arterial hypertension, which is group 1 pulmonary hypertension, would be that plus a low wedge, less than 15, and they put back the PVR, pulmonary vascular resistance, of less than 3 Wood units into the definition again. This is the classification of pulmonary hypertension groups, and the most important thing probably to pay attention to after the World Symposium is moving chronic hemolytic anemia from group 1 all the way to group 5 under pulmonary hypertension due to multifactorial issues. Most of the treatments that people study and work on are for this group of patients, group 1. You're familiar with group 2 due to left heart disease. Of course, group 3 is due to underlying lung disease. Group 4 is chronic thromboembolic pulmonary hypertension, and of course, multifactorial is group 5. So pulmonary hypertension is not uncommon. Pulmonary arterial hypertension is uncommon. It will always remain that the most common reason for pulmonary hypertension in general is left heart disease. So as you're treating heart failure patients, keep in mind that most of the pulmonary hypertension in the healthcare system are probably seen in patients that you're treating, whether they have systolic or diastolic heart failure, valvular disease, or even congenital heart disease. The pathogenesis has been established for a while now. It involves usually some predisposition in patients who develop pulmonary hypertension, and they're susceptible. There are risk factors, including toxins, portal hypertension, congenital heart disease, etc., collagen vascular disease. This leads to a vascular injury, which manifests as decreased nitric oxide synthesis, decreased prostacyclins, and increased endothelin and thromboxane. This eventually leads to arteriopathy of the pulmonary vessels in the form of intimal and adventitial proliferation and medial hypertrophy and thrombosis in situ, which characterizes the plexiform lesions that we see in pulmonary hypertension pathology. So it appears actually that patients who are genetically susceptible are more likely to be affected by insults that lead to pulmonary hypertension than patients who are not. This is from the recent publication after the World Symposium on Pulmonary Hypertension. And when you have genetically susceptible people, they're more likely to develop more severe disease than the genetically non-susceptible patients. Regarding the right heart in the pathogenesis of pulmonary hypertension, there's obviously pressure overload on the right side of the heart, leading to increased RV wall stress and neurohormonal activation, just like we see with left-sided heart failure. And this, of course, leads to myocardial remodeling and further maladaptation, and eventually dilatation and failure. And this is exactly the end point of pulmonary hypertension that we try to avoid when we're trying to manage these patients. In the setting of left heart disease, there is obviously the passive increase in the mean pulmonary artery pressure because of the primary pathology on the left side. This leads to an added component of pulmonary artery increasing pressures because of endothelial dysfunction and decreased nitric oxide, and ultimately this becomes a fixed pathology in the form of vascular remodeling and decreased vascular compliance. So when we see pulmonary hypertension in the setting of left heart disease, it starts with a reactive phase, and then the reactive phase becomes a fixed phase with time. This is a classic slide in pulmonary hypertension. It basically denotes the relationship between the pulmonary artery pressure, the pulmonary vascular resistance, and the cardiac output. So earlier here in this stage, when patients are asymptomatic, the cardiac output is preserved. There's the pulmonary artery pressure is rising, and the pulmonary vascular resistance is rising. As patients start developing symptoms, the cardiac output starts going down, and that's primarily why they start having symptoms, while the pulmonary artery pressure and the PVR are still going up. And in advanced stages, you start seeing that the pulmonary artery pressure is now going down because of RV failure and the inability to actually generate pressures. You have to keep this equation in mind. Cardiac output is transpulmonary gradient divided by PVR. Transpulmonary gradient is the mean pulmonary artery pressure minus the pulmonary capillary wedge pressure. Symptoms are non-specific, and that's in part why these patients get lost in the system for a long time. So the average time to diagnose patients with pulmonary hypertension is 14 to 16 months. And that's mainly because their symptoms are non-specific, and they get seen by multiple specialists without directing them in the right channels for diagnosis and management of pulmonary hypertension. However, most commonly, they will still complain of dyspnea. Some of them complain of fatigue, syncope or near syncope. And I've seen patients who were referred to us after a lengthy process of referrals between different subspecialists without understanding that the primary reason for symptoms was pulmonary hypertension. This is the WHO classification of their symptomatology. It's derived from the New York Heart Association functional classification. It's kind of similar to it. I just wanted to highlight that in class 4, patients are already manifesting right-sided failure, and if patients are presenting with syncope, they are automatically considered class 4 WHO symptom-wise. Cardiac findings in pulmonary hypertension. This is for academic interest and teaching. There is elevated JVP with potentially prominent A and V waves. There's the right-sided heave on the left sternal border because of left ventricular hypertrophy. Accentuated P2, early systolic click or mid-systolic ejection murmur. And then, of course, right ventricular S3 or S4 as opposed to left ventricular S3, S4. Systolic murmur of TR and diastolic murmur of PI. Please look at the right-sided right ventricular hypertrophy and right-sided strain pattern when you're looking at the EKG, because many times this is missed by even cardiologists when they're seeing ECGs. And this is an early finding that could help prevent detrimental progress on the pathophysiology. Radiologically, you'll see right ventricular hyper-enlargement with obliteration of the retrosternal space, prominent pulmonary arteries and central and peripheral hypovascularity in patients with pulmonary artery hypertension. Echocardiography is a fundamental test when you're working up patients with pulmonary hypertension. You're looking for right ventricular enlargement, right atrial enlargement, septal straightening indicating RV overload, tricuspid regurgitation, sometimes pericardial effusion, and of course objective findings of decreased systolic function on the right side in the form of low TAPSE. So this is a classic echocardiogram of patients with severe pulmonary hypertension and right-sided failure. As far as cardiac catheterization is concerned, this seems to be a debatable issue, when you're discussing this with people who are not managing pulmonary hypertension regularly. But the bottom line is, and this is by all guidelines and all symposia, catheterization is mandatory when you're trying to establish the diagnosis of pulmonary hypertension, not just to find out whether the patient has pulmonary hypertension or not, but to actually decide what kind of pathology the patient has. Is it secondary to the left side of the heart? Is it on the right side of the heart? And also determine the prognosis of the disease. And importantly, to perform a vasodilatory test, because if patients are reversible, then the management is different from irreversible pulmonary hypertension. So this diagram just basically shows you that depending on the site of the elevated pressures and the primary pathology, you can end up with pre-capillary pulmonary hypertension, post-capillary pulmonary hypertension, or even mixed pulmonary hypertension, depending on your wedge pressure as well as the calculated pulmonary vascular resistance. The vasodilatory challenge is important, again, because it determines whether you can treat patients at the beginning, at least, with calcium channel blockers. Admittedly, the responders or reversible patients in the setting of pulmonary hypertension or pulmonary arterial hypertension, that's group 1, is only 5 to 10%. But if you find these 5 to 10%, you can at least start them with calcium channel blockers and reassess their responsiveness. The definition of response when you're using a vasodilator in the cath lab is a decrease in the mean pulmonary artery pressure by more than 10 and decreasing the mean pulmonary artery pressure to less than 40 while maintaining or increasing the cardiac output. So if the pressure doesn't drop below 40, the mean, and it doesn't drop by more than 10 points, or if the cardiac output decreases, then we'll consider the patient unresponsive. Nitric oxide, inhaled nitric oxide is the recommended vasodilator to use in the cath lab for vasodilatory challenge, but people used IV epoprostenol or adenosine too. In advanced heart failure patients that we work up for heart failure and transplant, we actually sometimes use sodium nitroprusside in these patients to see if they're reversible or not. Now, within the guidelines, there are discussions on screening patients who are at higher risk for developing pulmonary hypertension. This is a known genetic mutation, autosomal dominant with incomplete penetrance, the bone morphogenic protein receptor 2 mutation, and these patients, 20% of them have a chance of developing pulmonary arterial hypertension. So you have to do an echocardiogram on them yearly, and the same applies to other associated conditions like systemic sclerosis, HIV, portal hypertension, and congenital heart disease according to these guidelines. And systemic sclerosis, it's also important to screen patients if the DLCO, the diffusion capacity, decreases significantly without an explanation. The diagnostic algorithm is really the same whether you're a pulmonary hypertension expert or not an expert. What is important when you're diagnosing people with pulmonary hypertension is whether or not you do follow through by doing all the necessary tests from the beginning to the end to establish the diagnosis of pulmonary arterial hypertension definitively and start treatment at the right time before it's too late. So you can either do that if you have that available to you, or you can refer patients to experienced centers. The guidelines talk about referring patients to experienced centers for pulmonary hypertension diagnosis and management, because these centers are usually the centers that can start and end the diagnostic algorithm of all these tests and follow up with contingent tests if these initial tests are positive or indeterminate to look for specific suspected conditions. So make sure the process is followed, again, regardless of where and how it's followed, as long as it's followed. There are specifically 3 established pathways and 4 established classes of medications in the management of pulmonary hypertension. There is the endothelin pathway, and for that we use endothelin receptor antagonists, whether they block receptor A only or receptor A and B. There is the nitric oxide pathway, and the nitric oxide pathway is where phosphodiesterase inhibitors work to prevent the degradation of cyclic GMP, or where soluble guanylate cyclase stimulators work to increase the production of cyclic GMP. So these two are working on the nitric oxide pathway. And then of course there is the prostacyclin pathway to increase the availability of cyclic AMP eventually through prostacyclins. The treatment goals is to improve survival, improve quality of life, improve exercise capacity. That's why you will see as a primary endpoint for many of the pulmonary hypertension studies, the 6-minute walk distance and the functional classification, the WHO functional classification improvement. Many of the studies have this as the primary endpoint. We want to have less severe symptoms, and we want to prevent clinical worsening in the form of escalation of therapy, hospitalization, lung transplantation, or death. There are certain high-risk markers and certain lower-risk markers, but once you have clinical evidence of right heart failure, it's bad news. If the patient has progression of symptoms that is going rapidly, is also a higher risk for patients with pulmonary hypertension. Class 4 WHO, shorter distance, 6-minute walk distance, less than 300 meters, peak VO2 of less than 10.4, findings on echocardiography, right atrial pressure more than 20, or index of less than 2. And of course, if the BNP is significantly elevated. These are the red flags as far as the poor prognosis in patients with pulmonary hypertension. And this is the Fifth World Symposium guidelines. These are the guidelines that were just published as far as medications that you use for pulmonary hypertension management. And they actually did two things. They gave the class of recommendation, 1, 2A, but of course 2B is not that encouraging. So class 1 is where you definitely have to use the medication. Class 2A is where you should consider you should consider the medication. And they also broke it down by the WHO functional class. Most of these medications were studied in functional class 2 or 3, and that's why you see most of them listed here. The ones listed in yellow are the ones that were studied in clinical trials and used mortality and morbidity as an endpoint. Mesitantan, for example, is the only endothelin receptor antagonist that used time to clinical worsening as an endpoint, a composite endpoint. Epoprostenol, of course, is the only medication that showed clear survival benefit in pulmonary arterial hypertension in a randomized clinical trials. And of course, all of the other medications looked at 6-minute walk test, functional improvement, symptom improvement, and looked at a clinical worsening as a secondary endpoint. So the treatment algorithm caveat here, and this is more of a side point, is that since that time, oral treprostinil, which is another prostacyclin used in pulmonary hypertension management, has been approved by the FDA. This is good news because it's an oral medication. However, it was also one of those medications that were studied and showed increased 6-minute walk distance, no mortality findings. So this is how it looks like as far as the medications. This is what I just showed you in the table. I wanted to show you how they go with the algorithm from the beginning. You have to consider expert referral early on if you think that there is no ability to fulfill all the diagnostic algorithm and manage the patients. You have to use the acute vasoreactivity testing. And then if the patient is vasoreactive, you have to start a calcium channel blocker and reassess response. If the response is good and maintained, then you continue calcium channel blocker. If it's not, then you consider switching to another therapy, and you go by the protocol we discussed. If there is inadequate clinical response, then you consider combination therapy, and then you have different ways you can combine medications, endothelin receptor antagonists, prostanoids, or PDE5 inhibitors, or soluble guanylate cyclase stimulators. Of course, if there is no response, then you are evaluating the patient for lung transplantation or heart-lung transplantation, or considering an advanced surgical procedure in the form of atrial septostomy. Atrial septostomy basically creates a right to left shunt. It decreases right heart filling pressures, but it has a high mortality rate ranging from 15 to 50%. And of course, invasively, your last resort is lung or combined heart and lung transplantation, which is only done at very, very peculiar centers around the world, and it's very hard to manage. So in summary, pulmonary hypertension is common, but most often due to left heart disease or lung disease, so please keep this in mind. Pulmonary vasodilators, these pulmonary arterial hypertension medications that I was discussing with you are not beneficial in these patients. You don't treat heart disease, pulmonary hypertension with these vasodilators. Pulmonary arterial hypertension is rare but deadly, so you have to establish diagnosis early. The definitive diagnosis of pulmonary hypertension requires right heart cath. It's part of the diagnostic workup. You have to identify the underlying cause of pulmonary hypertension. The treatment of pulmonary hypertension is based on correct diagnosis and functional status, and the lack of response to acute vasodilator challenge in pulmonary arterial hypertension does not mean that the patient is untreatable. Thank you.
Thank you, Dr.